everyone. To all the medical coders, auditors, and clinical documentation specialists out there, welcome. If you've ever felt completely tangled up in the 2023 medical decision-making guidelines, well, you're in exactly the right place. We're about to take all that complexity and turn it into a super clear visual blueprint you can start using, like, today. Okay, let's jump right in.
Okay, for just a second, forget trying to memorize every single little detail. If you only take one thing away from this whole explainer, make it this. This is the master formula. The entire system, and I mean all of it, boils down to 3 pillars: problems, data, and risk. And to figure out your final MDM level, you only need to meet or exceed the criteria for 2 of those 3. That's it. It's the rule of 2, and it's going to be our guide for everything we talk about next.
So here's our game plan. We've touched on the master formula. Next, we're going to break down each of those 3 pillars one by one, sizing up the problems, analyzing the data, and calculating the risk. And then we'll pull it all together so you can totally master the final MDM grid. It's really a straight shot from confusing to crystal clear. All right, let's start building our score with the first pillar, problems. This is all about looking at the number and, more importantly, the complexity of the issues that were actually dealt with during the encounter. Okay, so what does addressed actually mean? This is where a lot of people get tripped up. You absolutely get credit if you evaluated or treated a problem, if you're co-managing it, or, and this is a big one, even if you talked about a treatment and the patient said no. That counts, but you don't get credit for just mentioning a problem, like saying, Dr. Smith is handling the hypertension. That doesn't fly. It has to be about active management or evaluation in this encounter. So for acute problems, this is a fantastic way to think about it. The severity staircase. At the bottom, you've got minimal, self-limited stuff, right? Like a simple ankle sprain. Then you climb up a step to acute, uncomplicated problems. Then another step to acute, complicated issues, all the way to the top, where you have a direct threat to life or limb, like a pulmonary embolism. It just makes scoring so much more intuitive. And for chronic illnesses, we've got this matrix. It seems simple: stable, exacerbated, or severely exacerbated. But wait, look at that red box. This is so important. A patient who is not at their treatment goal is considered unstable, even if their condition hasn't changed. So think about a patient with high blood pressure. If it's still high, even if it's the same as the last visit, they aren't at goal. That means it's unstable. All right, pillar 1 is down. Let's move on to pillar 2, analyzing the data. I like to think of this as the detective work of coding. It's all about piecing together the information the provider reviewed to make their decisions. So the guidelines break data into 3 clear categories. Category 1 is all about gathering info, reviewing old notes, ordering new tests, or getting history from somebody who isn't the patient. You know, like a parent or a spouse filling in the gaps. That's called an independent historian. Category 2 is for your provider's own independent interpretation of a test. And Category 3 is for when they discuss the case with another professional. Each one has its own points. Now hold on. Before we go any further, we have to talk about the biggest, most important pitfall in this pillar: the double-dipping rule. It's so simple, but so critical. You absolutely cannot count an independent interpretation towards your MDM level if you are also billing for it with a separate CPT code. It's one or the other. You have to choose. This flowchart makes it super clear. Let's say your provider independently interprets a chest X-ray. If they are the one billing the CPT code for that read, you stop right there. You can't count it for MDM. But if someone else, say a radiologist in a different group, is billing for the official read, then yes, your provider can absolutely count their review and interpretation toward their data points. So how does this all add up? This data scoring engine shows you exactly how. To get to a limited data level, you just need to hit the mark in one of 2 categories. For moderate, 1 of 3. But here's the kicker for extensive. To get to that highest level, you have to meet the requirements for at least 2 different categories. That's a huge detail to remember. And that brings us to our third and final pillar: calculating risk. You know, a really common mistake is thinking that risk is all about the patient's final diagnosis. It's not. The risk level actually comes from the management options the provider considers. It's all about the treatment plan. So your final risk profile is a mix of the problem itself and the treatment options. And there are 3 essential rules here. The ultimate plan rule means the risk is based on what you considered, even if the final diagnosis turns out to be something simple. The shared decision-making rule gives you credit for discussing options, even if the patient says no. And the palliative exemption is key.
deciding not to hospitalize a palliative care patient can still be a high-risk decision.
Think of this as a map of risk. It gives you a great visual. You can see how different decisions fit into low, moderate, or high risk. For instance, suggesting an over-the-counter drug. That's low risk. But the moment you manage a prescription drug, you've jumped into moderate risk. And a decision about whether or not to hospitalize someone, that puts you straight into the high-risk category. Okay, we did it. We've broken down all 3 pillars. And now for the big payoff. Let's bring it all home and see how to use the single most powerful tool in this entire process, the MDM grid.
And there it is. It's this simple. You take your score from Pillar 1, problems. You get your score from Pillar 2, data. And you get your score from Pillar 3, risk. You just plot them on this grid, and remember what we said at the very beginning? The rule of 2. Your final MDM level is whatever level you hit in 2 out of the 3 pillars. That's the whole thing. It really is that straightforward. Let's run through a few tricky real-world scenarios. First up, the patient says no. The patient refuses a test. Does it count? You bet it does. As long as the risk/benefit discussion is documented, you get credit. Second, the scary symptom. Patient comes in with chest pain, but it turns out to be muscular. The risk isn't based on the final diagnosis, it's based on the high-stakes condition you had to rule out. And third, unchanged but unstable. Remember that patient with high blood pressure who's not at goal? That elevates the problem's complexity right there. So as we wrap up, let's lock in these golden rules. 1. Never ever double-dip data between a CPT code and your MDM. 2. A language translator is not an independent historian. An independent historian provides actual patient history. 3. Addressing social determinants of health that significantly complicate treatment. That counts as moderate risk. And 4. Comorbidities only count if you document exactly how they increase the data you had to review or the risk of that specific encounter.
We've built the whole blueprint, from that simple master formula all the way to the final grid. So now I have a question for you. Thinking about all these rules and common pitfalls we've uncovered, which one is going to change the way you code tomorrow?